Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration of how to improve health and healthcare. New research is transforming the outlook for cervical and uterine cancers, two of the most serious gynecologic malignancies worldwide. And one of the people shaping that progress is with us today. She's Dr. Mary McCormack, the Senior Clinical Oncologist for Gynecologic Cancer at University College London Hospitals. Dr. McCormack has been a driving force in clinical research in the field, contributing to numerous national and international trials, and leading the INTERLACE study, which changed global practice in the treatment of locally advanced cervical cancer. She was named to Time Magazine's 2025 list of the 100 most influential people in health, and she's known as a strong advocate for improving outcomes and access for women facing these diagnoses. Today we'll discuss how her research is transforming care and what lies ahead for women's cancer treatment worldwide. Thank you so much for joining us today.
Thank you, Michael, for the invitation. I'm delighted to be here.
We always like to start by learning more about our guests and what got them interested in medicine, and in your case, focusing on gynecological cancer. So what was that story arc for you?
I was in science before I swerved towards medicine. So I was doing a PhD in radiation biology and trying to explain some set of clinical findings with cervical cancer, actually, as it turned out. And trying to understand the link between cancer-induced anemia and radiation and why some of the cancers were seen to respond poorly. So this was back in the 80s. And I was struck by the fact that it's quite difficult it was certainly in those days, it was quite difficult to do clinical research. The clinicians and the scientists were sort of in separate silos. And it really spurred my interest. I became more interested in oncology as a subject and then decided to do medicine to pursue a career in oncology. And then as a junior doctor, I had a superb mentor in a gynecologist who sort of took me under her wing. She herself had trained as a gynecologist and then became an oncologist and was a radiation oncologist, but also gave chemotherapy. So what we call in the UK a clinical oncologist. So really that then set me on the path of general training and then specialty training, and then obviously looking for a career post within our national health system as a clinical oncologist to pursue my interest in gynae cancers.
So it's the reverse of what we hear from a lot of guests. I mean, you started with research as your interest,
Yes.
and becoming a doctor helped, sort of facilitate that, as opposed to people getting into medicine and then discovering they really liked research.
Yes, indeed.
Talk about how the patient care influences and interplays with the research work that you do.
Well, I think, first of all, we have to gain the confidence of our patients if we want them to participate, to gain the confidence of our patients anyway, to pursue a course of treatment, to follow and work with you to make sure that they get through it. And I think there's nowhere where that's more important than when we give long courses of radiation with or without drug treatment. It's a tough course. It's exhausting. It's challenging financially and socially. And so we have to gain our patients' trust and maintain that relationship to get them through. And I think when we manage to do that at the outset by spending time with them and understanding their needs as well, it's easier then to get those patients interested in participating in research. And I always find that the time investment at that first opportunity when you meet the patient is of utmost importance, because that's your opportunity to gain their trust and to sort of be able to then use that or help them to make the decisions that they really need to make to improve their likelihood of a cure with their particular cancer, or improving their symptoms if it's in the palliative setting. So I think that first interaction is key.
Yeah. What is the landscape like for clinical trial recruitment in the UK? It's obviously can be very difficult depending on the patient population you have to work with and how rare the disease is and so forth. But is it generally a real challenge, or is there receptivity to that in the UK generally?
There are challenges, and I think there are more challenges in certain subjects than there are in others. So, depending upon the number of cases of particular cancers, and you touched upon the fact that some cancers are relatively rare. For example, gynecological cancers, particularly in the UK, relative to, say, breast cancer, bowel cancer, or prostate cancer. So I think it's making sure that there's advocacy, that patients understand that progress is made through participation in clinical trials. And so having that sort of narrative out there that patients will talk about through chat groups and forums, that's really important. But again, then it's having the time to dedicate, or making the time to dedicate to explaining to a patient what the options are, that there's the standard of care treatment or there's participation in a clinical trial. And there's no doubt that to do that and to do it well, it takes time. So it lengthens the consultation. And if you're rushed for time, there may be a tendency, and I suspect this happens, to just go ahead with the standard of care treatment because you don't actually have time to get involved in discussing what the trial will involve, the pros and cons, bringing them back on another day, taking consent, and going through that whole process that's involved in actually recruiting somebody to a clinical trial. And I think it's fair to say that when we're stretched and when our resources are stretched, that's probably one of the first things that takes a hit.
Yeah, I mean, one of many, many reasons why the squeeze on physicians for the amount of time they get to spend in an appointment is just so counterproductive. To get a little bit more into the particulars, you devoted many years to studying adjustments to chemotherapy and radiation therapies for patients with advanced cervical cancer. So what set you into that area of investigation, trying to figure out that interplay?
Well, I was appointed as a consultant, a full-time consultant in 2002. And in 2003, there was a publication of a meta-analysis of outcomes in cervical cancer, specifically addressing the question of giving chemotherapy upfront before radiation, because in those days, radiation was the standard of care, not chemoradiation as it is today. And there were multiple trials that were carried out in the 90s, and the results were really there were quite heterogeneous trials, relatively small numbers of patients, and so there were very mixed results. But within the meta-analysis, there was a suggestion that if you gave short cycle chemotherapy, that it might actually be associated with an improvement in outcome. But for sure, if you gave the longer cycles, i.e. give 21 or 28 days between courses of chemotherapy, that might actually be that was detrimental to patient outcome. So really the news that was out there around upfront chemotherapy was it's bad news, bad, bad, bad. It's associated with really poor outcomes. So we're not even going to look at it again. So what I did initially was to go back and really look at all those factors again and think about what were the things that we could change to really build on this possibility that if you gave the chemo with shorter intervals, that it might actually be associated with an improvement in outcome. So we considered what's the most aggressive schedule you can give with the drugs that we have that are most effective in gynecological cancer, and that was weekly treatment. And of course, the older trials had not used the taxanes, which have become the cornerstone of systemic chemotherapy in gynecological cancers. And what the trials didn't take into consideration and the meta-analysis didn't address was there an impact of this delay between, or the interval or the gap between finishing the chemo and starting the radiation? I think this is partly where my background and, my understanding and my thinking about radiation biology came into play as well. Would that make a difference? So if we corrected all those things that we thought that maybe were detrimental, then would that make a difference? So first of all, I had to do a phase 2 study. So because cervical cancer is not a common cancer in the UK, it took a little bit of time, one, to get some money for that, and two, to actually do the study. We recruited just 46 patients, but what we quite clearly demonstrated was that we were able to get all the patients through the chemo phase and subsequent radiation with chemotherapy, which was by then the standard of care. So that was the first thing to show that we could do it and it was feasible. And then what we were able to show was that at the end of this 6 weeks of chemotherapy, we subjected all the patients, had an additional MRI scan of the pelvis, and we were able to show that the 70% objective response rate, like partial or complete response, at the end of just 6 weeks of treatment. So that actually was really quite encouraging. And then when we looked at the outcome at 3 and 5 years, small numbers, of course, you can't draw any conclusions, but the outcome appeared to be better than the historical controls. And as it was, an audit had been published of UK outcome data around that time. And so our outcome appeared to be better. At least it wasn't worse than what we were seeing with just standard of care chemoradiation following its introduction, sort of in the early 2000s. Okay, so now we have some data, we have some phase 2 data. So then we start the process of trying to obtain funding for a clinical trial. So we managed, after a lot of work goes into writing an application for funding, and Cancer Research UK agreed to fund the trial. But I had to do a lot of work actually to get other sites interested. So it involved, going to various meetings. Nothing was online back in the early 2000s. It was all in person. So travel to meetings, go to international groups, and try and, garner some support for this concept. And it's fair to say that there were some people, some nationally, but some internationally, that thought this was the most dreadful idea ever. And so we're not going to support it. And when I proposed this clinical trial, some of my colleagues on the other side of the world in Australasia decided that they were going to do a clinical trial and give chemo, but give it after the radiation. And there was really, I thought it lacked a bit of rationale as to why you would do it then. But nevertheless, that was adopted by our American colleagues, and that recruited. So we had 2 trials running in a rare cancer at the same time. Didn't help recruitment to the INTERLACE trial. Plus they had money, they had some money to pay for participating centers, and we didn't. So there were lots of challenges in recruiting, in the sense of getting sites on board, but we just had to persist, because I couldn't possibly conceive of having started something and not getting to the end. So it was a dogged determination to complete it, and at least then we had an opportunity to answer the questions as to whether it helped or not.
Yeah, I mean, this really is a story of persistence, and I think a good lesson for the med students and early career professionals, kind of setting expectations for what it can be like, to pursue a clinical trial like this. So, in fact, I think I remember reading that at one point you were in jeopardy of not having the funding to sustain the trial and had to make some adjustments.
Not quite. We had difficulties holding on to our grant because our funders thought, well, this trial is taking too long. Then is it worthwhile continuing to fund it? But we did manage to persuade them that it was worthwhile. We had to take a pause, and then my own institution stepped in for a year, provided funding, which I was very grateful for, because they believed in it. And what we did do was we did try to look for funding elsewhere from the NCI and from other institutions for example, a group in India to join. And, there were some suggestions that they might be interested in helping, because this was sort of a developing world country, and this was in the pursuit of academic clinical trials in such a setting, really important, and really important for cervical cancer, because of course this cancer is much more common in parts of the world like sub-Saharan Africa, Southeast Asia, South America, where, there aren't any screening programs. But that all came to nothing, unfortunately. So we did, again, through the generosity of my own sort of research institution, find some money to assist with setting up the trial in 2 hospitals in India. We could have recruited 10 times the number of patients, but we simply didn't have the funds. We had a fantastic champion locally there who used some of her own meager research funds as well to sponsor those patients, so they didn't have to pay for the drugs.
Well, with that remarkable backstory, let's get into the medicine and the science here a little bit. So this trial, INTERLACE trial, as I mentioned in the introduction, has changed how locally advanced cervical cancer is treated. So give us a high-level understanding of the trial and what new protocols have emerged from it?
So what we did, it was a phase 3 trial. So we took previously untreated patients with cervical cancer confined to the pelvis, and we randomized those patients that were fit and well enough to receive chemotherapy with radiation, to have either the standard of care protocol, which was daily radiotherapy with once weekly chemotherapy called chemoradiation and brachytherapy. And the experimental group had 6 weeks of the combination of carboplatin and paclitaxel chemotherapy. And then in week 7, they started the same protocol of radiation as the standard of care group. So in other words, the only differences between those groups, they were well matched, was that our test group had an additional 6 weeks of chemo before they started the standard chemo rads. So what we found when we analysed the data, and with a good follow-up of 67, median follow-up of 67 months, so quite mature data, we found that there was a significant improvement in both progression-free survival and in overall survival. Now, we often talk about something that's statistically significant, and we need to know, is it clinically relevant? Well, an 8% improvement in the overall survival rate at 5 years is clinically meaningful, and obviously it was highly statistically significant. We were also able to demonstrate that we had fewer distant relapses, so outside of the irradiated area, in patients who had received the additional chemo. And part of our logic for this approach was thinking we might be able to treat micrometastatic disease. So are we able to tackle cells that we can't see, but are undoubtedly probably there for a lot of patients before they start any treatment?
Remarkable. Well, congratulations, I should say, because this is really quite amazing. So what's your sense of how widely the protocol is being adapted, and what's your expectation for, its impact over time?
Well, you can imagine there was a lot of excitement about it, and even the detractors from the study had to actually acknowledge that it didn't cause harm, this approach, when the protocol was delivered in the way it was intended to be given. And I think that's really important because, unfortunately, there will be those that will think, we can just give it every 3 weeks and we'll have the same outcome, those drugs, because we'll reduce the patient visits. But that's really essential that they don't do that, that they stick to the protocol to get the desired outcome. In answer to your question, I've done many, many, many podcasts with different groups from Central America, South America to Asia. And in general, the protocol has been well received, and it's perceived as deliverable. The drugs are readily available. They're not expensive, although, of course, that's always depends on your starting point and where you are. And in some communities, they're still expensive, but on the whole, they're cheap. And the protocol and this approach to treating cancer was adopted into the NCCN guidelines in April of this year. So that's a really big deal because lots of centers, particularly in the South and Central America and Southeast Asia, etc., they follow the NCCN lead, and they look at those guidelines. Many of the centres here in the UK have also adopted it, and colleagues in Europe, to a variable extent, have adopted the protocol as well.
You made an interesting point there about it was deliverable. I mean, it was possible to do it because there are clinical trials where the drugs are not as widely available, or the process is too expensive because of the physician involvement and stuff. So that's an essential piece of this, right?
Absolutely, absolutely. I mean, there was another trial that reported around the same time as INTERLACE, and that was looking at using immunotherapy. And, one, it's a very expensive drug. And two, the protocol demands that the patient has that treatment for 2 years. So that's a phenomenal cost, and it's way outside of what centers in, places like India or Africa or even South America. I mean, they're just not going to be able to afford that kind of care. So it's unaffordable. That's not to say that there aren't some merits in it, but it's unaffordable. Unlike, INTERLACE, which is considerably cheaper.
Excellent. So I noted also at the beginning you've contributed to a lot of national, international trials. So I'm wondering from, that experience, that perspective that you've gained through all of that, where do you see the greatest unmet needs in gynecologic oncology research today?
I think, there are a number of unmet needs, and one of them is providing adequate radiation facilities for the management of cervical cancer, because this is the most common gynecological cancer worldwide. And it's in the top 2 or 3 cancers in women worldwide. And it obviously targets, it generally speaking, a younger population, so it can impact a very wide, part of the community, because it's usually younger women. So you have children that may be left motherless. Often the women are in the homemakers or contributing to the finances. And so it really is a major problem. So that remains a challenge. And lots of people, including the WHO a couple of years ago, made it one of their mission statements to try to eradicate cervical cancer by 2030. I mean, really, I think it's probably not achievable. It's a laudable aim. What we really need is to pursue and try and improve the uptake of the vaccination schedules, because it is one of the greatest success stories that we understand so well, the natural history of cervical cancer. And we can do something about it that can reduce the incidence of developing it. And I think that's what we really need to focus on for many parts of the world where it will maybe take decades to improve radiotherapy facilities. In fact, we've talked about this for the entire time I think I've been in oncology, and we haven't made a great deal of progress as an international community, because you can't come in and just dump a machine somewhere. There has to be buy-in from the providers in those countries, and they need to see it as a priority, and then they need to provide engineers and trained staff and support, etc., to maintain those very expensive pieces of equipment. So I think we have to look at trying to prevent this problem. So that's one area. Obviously, for those of us who are fortunate to have access to good quality care, then there are always going to be some that will relapse after best standard of care treatment. So how do we best treat those? And in particular, how do we treat them when we've used our immunotherapy option? And how can we make this a more chronic illness when patients relapse, rather than something where patients will die within a couple of years of relapse? Obviously, there are challenges in managing ovarian cancer as well, and there've been certainly been progress, but the outcomes are still lagging for the majority of patients. Immunotherapy is now playing a big role in endometrial cancer treatment, but again, it's going to be access to those drugs in other parts of the world. But I think cervix is still the most common gynecological cancer, and I think access to adequate treatment, not just in the low resource settings, but there's lots of disparities even in the high resource settings.
Oh, absolutely.
So we really need to try and address those issues, and we need stronger advocates.
Yeah. No, the inequity of access to care in the United States remains, a top concern. So Osmosis is a teaching company, and we always like to give our guests an opportunity to give us some guidance about what we should be providing to medical education that's maybe not there now. So some gap in knowledge, something you wish medical schools were teaching. What would fit that bill for you?
I think in oncology, a bigger focus on diagnostics, on interpretation of imaging. I don't know if that's part of the curriculum in the States. It's not a major part of our curriculum here in our training grades, especially in oncology. And that really comes into play when we think about radiotherapy planning. We have to be able to identify the sites of disease. We need to be able to map them out confidently. And that's our first step in delivering a good plan to treat a patient with radiotherapy. So I think a better integration and more integration of imaging into the curriculum would be good. I think, from an educational point of view as well, just providing frequent updates in very small snippets on what are the latest treatments that have been demonstrated to be effective, particularly ones where they're supported by a publication or incorporation into guidelines. And really for clinicians who are too busy to attend meetings, because those of us that know the data, but it's distilling it more widely and making sure that everybody understands what the go-to and what the sort of the recent advances are. And I always find those educational sessions, I think they're immensely helpful, and they're in an easily digestible format. Then they can provide an update for, somebody giving up an hour or half an hour of their time. They can achieve something really quite useful.
Well, yes, and there's such a volume of research coming out, and there's so many new technologies coming out. You can see how people just, get lost.
It's very difficult to stay ahead of it. Absolutely.
So as we wrap up here, we always like to give our guests an opportunity to also provide some advice to the learners in our audience and early career professionals about meeting the challenges of a career in healthcare, and I think in particular your case, the clinical trial aspect of medicine.
I think first and foremost, we're in an era where you really need to work within a functional multidisciplinary team, and not to just pay lip service to it that we all work in silos, but we chat offline or whatever. You really need that bunch of people together in the setting. That's important because one, it supports younger and more junior colleagues in their decision making. And two, I think it helps to ensure that everybody is giving the best possible guidance to that patient. Not everybody, of course, very few will have met the individual, but on the basis of what we know about their condition, etc., then to be able to give the best management and to advise on the best management, you really need to work within that team structure. And that's very important where you have private clinics or you have individuals working in institutions that don't necessarily have access to that. So I would say do that. It will pay dividends. If you're unaware of something, then perhaps one of your colleagues will say, there's a clinical trial that's going on here. Keep an eye on the clinicaltrials.gov because they will update people on the trials that are open and the centres that are recruiting. And I think it's really important in this day and age that we look after ourselves as healthcare professionals and that we try to establish a good work-life balance, because there's no doubt that oncology is quite draining. Patients see you as their savior, and we're not gods. We can't always get the desired result, much as we might want to for our patients. So it's managing their expectations and then looking after our own mental health as well, because it's something that's frequently overlooked. Nobody tells you how to do that. Nobody says to you, you need to maintain a good work-life balance, and they don't necessarily check on you to make sure you're doing it. So if you want to have a long career, that's ultimately very demanding, just even in routine clinical practice or in clinical practice where there's a research element, you still need to look after yourself. So I think that's really important.
Excellent advice. Really wonderful advice for our audience to absorb and contemplate. And I just want to thank you so much for that and for spending so much time with us today. We really appreciate it.
Thank you, Michael.
I'm Michael Carrese. Thanks for checking out today's show. And remember to do your part to raise the line and improve the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.